Hi everyone, I want to talk about hypokalemia. Hypo, low. When it's too low, you run into trouble. Okay, let's go. Hypokalemia, the normal range of potassium is expected to be between 3.5 milliequivalent to 5.2 milliequivalent per liter. Some authorities will write anything between 3.3 to 5.0 and so on and so forth. It is hypokalemia when it is less than 3.5 milliequivalent per liter. It is mine at 3.0 to 3.5, moderate at 2.5 to 3.0, and it is severe when it's less than 2.5 milliequivalent per liter. What are the causes here? Diuretics. In fact, all diuretics except potassium-sparing diuretics like spironolactone, amiloride, triamterene, the rest will send potassium out. No, insulin is even worse, like lases, etacrinic acid, bumetamide, and thiazide diuretics will do the same. Hydrochlorothiazide, chlorthalidone, all of them will send potassium out, will give hypokalemia. Hyperaldosteronism, there'll be a separate presentation on that, so I will not go into details right now. Diaphoresis, sweating profusely. Dialysis, stuff going up and down, moving between the blood and the machine and everything like that. Plasmapheresis, polyuria, vomiting and diarrhea, laxative abuse, tube drainage, renal tubular acidosis, and decreased magnesium. Increased insulin. If you have listened to my presentation on hyperkalemia, you will understand the way insulin will lead to hypokalemia because we use insulin to treat hyperkalemia. So I won't go into that details once again. Increased pH, also check my presentation on hyperkalemia. Salbutamol is also listed there. And decreased potassium intake. Of course, you don't get what you don't have. When you don't take potassium in, where are you going to get it? Hypothermia, chloroquine toxicity, risperidone, quetiapine. Those two medications are second-generation antipsychotics. So when your patients are on them, or you are on them, or any of your family members, ask for the value of the potassium. Yes, what are the clinical features? The first thing to consider is it rapidly dropping? Is the value less than 3.0 milliequivalent per liter? Is this person on digoxin? I've made presentation on digoxin from A to Z, and I won't go into that details again. Just go and check my presentation on digoxin, and you know the relationship between digoxin and potassium that are competing for binding site. Muscle weakness. When it is very low, 2.5 milliequivalent per liter, then muscle weakness will set in. And the pattern of the muscle weakness will be like from lower extremities moving up. And some could wrongly diagnose that to be Guillain-Barré syndrome. But when you check the value of potassium, then you know what you're dealing with. There could be muscle cramps, tingling, and numbness. Still not done. Respiratory muscles could become weak and that will lead to respiratory failure and death. That's what we call paralytic eye loss. The intestinal wall will become flaccid, the peristalsis is not occurring. And with that, there's possibility of aspiration to the lungs and all the sequelae. Nausea, vomiting, abdominal distension when there's paralytic eye loss. And of course, the vomiting will lead to lower level of the potassium again. So making the situation to be what? It's not going to be improved. Don't tell me it's going to get worse. Yes, on the heart, we can have ventricular tachycardia that will progress to ventricular fibrillation. It's possible to have premature atrial contractions, premature ventricular contractions, sinus bradycardia, or atrioventricular node block. Wow. The low level of potassium is very detrimental and as well as difficult to handle if appropriate diagnosis is not made on timely basis. Also, hyperkalemia is not friendly. All we need is between the normal range. Check out my presentation on hyperkalemia as well. So you need to save the heart in hypokalemia, and you need to save the heart in hyperkalemia as well. EKG here will appear with decreased T wave, increase U wave, increase U wave. And your MCQ questions, you're not going to joke about hypokalemia and U wave on EKG. Okay? You may have prolonged QT and ST segment sagging. The prolonged QT could lead to torsade point. Torsade point could lead to ventricular tachycardia and to ventricular fibrillation, and from there progress to asystole, and the patient is on the way to mortuary. That is why it is so important to get this value right. But prolonged QT and torsade point are not related to hypokalemia alone. We'll make a separate presentation on prolonged QT later on, but let us get it right now that decreased magnesium and hypokalemia could contribute to this. When the kidney is damaged, we'll be dealing with increased blood pressure. As a matter of fact, the high level of potassium is associated with hypotension, while low level of potassium is associated with hypertension. So it is not strange to know that kidney could be damaged and there will be increase in blood pressure. Nephropathy, increased level of ammonia when the kidney is not doing its function. Hypostenuria cannot concentrate urine. The person can be having urinary incontinence or bedwetting. Thiazide-associated diabetes mellitus or hyperglycemia is as a result of hypokalemia-induced decreased insulin production. Get it right. Some of the side effects of thiazide, I'll make a separate presentation on thiazide later on. Some of the side effect is hyperglycemia. But here is the picture. The hyperglycemia from there is because there will be hypokalemia when a patient is on thiazide. So the hypokalemia would then lead to decreased insulin. And when insulin level is low or is dropped, what do you expect? You have the answer? Yes. Straightforward. Glucose will be high. That's it. How do we make diagnosis of this small but remarkable situation? Just do the electrolytes. Whether it's 7 panel or whatever, just do the electrolyte. Run after the potassium, sodium, magnesium, calcium, and all the likes. Do your renal function test. What's happening to the kidney here? Has it affected the heart? Run the EKG. And of course, rule out any problem going on in the heart with cardiac enzymes. So just get all this done. And it won't be out of place to get arterial blood gases here as well. How am I going to treat this? It depends on the level of the potassium. So if it's still mild, yeah, just advise on increasing the diet. I mean, diet containing potassium. The list here is not exhaustive. I mean, you can get more from your dietitian or from online or anywhere, that I've just decided to list this few. At least if you're able to get 2 or 3 of these, you should be fine. But then this is not taking the place of what your doctor will advise. So I'm not treating you from this presentation, okay? So avocado, we have potassium. Banana, peanuts, pork, tomatoes, and carrots, spinach, broccoli, oranges, lamb, and you can add potassium-sparing diuretics. Spironolactone, eplerenone, triamterene, amiloride. They will send the fluid out but keep the potassium. That is why in so many centers, some of us will choose to give thiazide and potassium sparing when we need to send the fluid out. And we want to save the heart and the central nervous system and muscle from hypokalemia. So we give potassium sparing while the other one is sending potassium out. You can give, if it is excessively low, you can give the potassium intravenously. Potassium chloride will come in form of liquid, tabs, or capsules as well. We have slow K, FRK, K-dot, K-light. This is not exhaustive as well. I mean, all these trade names, and I have no prior deal with any of the companies manufacturing these ones. I just listed these that I'm used to. Stop all possible means of loss. That is the major way to stop the loss of potassium here, leading to hypokalemia. Stop possible means of loss. And cardiac monitoring, please. Cardiac monitoring, please. We want to know what is happening to the heart so that we'll be able to help quickly. No dextrose here. You are good, you are kind, you want to help the patient, you want to place your IV fluid up, please, no D5 here, no D10 here. Why? You don't use dextrose in hypokalemia. The glucose will lead to insulin release. And if you are listening to my presentation on hyperkalemia, we'll employ the services of Mr. Insulin to help us send the potassium into the cells and to prevent hypoglycemia, we will place our dextrose up. So in this case, when you put the dextrose up for the patient, there will be high level of glucose Pancreas will start working, biliary cells will release more insulin. That insulin will send potassium into the cells, and you are down with worse situation. So there will be severe hypokalemia from dextrose infusion. So no dextrose. When my dad or my mom is down with hypokalemia, please don't add to the problem. In conclusion, we don't need potassium to be too high and we don't want it to be too low. So we are going to do more on electrolytes. Sodium could be sort of problem to many people, and hypo or hyperkalemia is a big headache. Magnesium, the value is not supposed to be too low, or else the heart will go into trouble. So review my presentation on hyperkalemia to enjoy this hypokalemia very well, and watch out for further presentations on the rest electrolytes. So thank you for watching my presentation. Kindly subscribe so that you can get all these things as soon as they're published. Thanks.